Thank you very much to the NAP for allowing me to come and talk to you today. I'm a consultant paediatric haematologist with NHS Blood and Transplant, previously for many years also joint consultant at St Mary's in Paddington. And what I want to tell you about today is the 2018 Paediatric National Comparative Audit on FFP and cryoprecipitate in neonates and children, which is actually due to start next Tuesday, so this is very timely. The audit is being run by the National Comparative Audit of Blood Transfusion Programme, which you also heard about earlier from Professor Foy in the Affinity project. And it's an independent clinical audit programme which is funded by NHS Blood and Transplant. It's included in the quality accounts list issued annually by the Healthcare Quality Improvement Partnership. And it runs 2 audits a year, and this time we're very pleased that this one is specifically focused on paediatric transfusion. The audit is aiming to look at areas which are particularly uncertain in paediatrics, namely, firstly, the use of FFP and cryoprecipitate, both for prophylaxis and in bleeding patients. And secondly, the transfusion management of bleeding overall, both in major hemorrhage but also in other situations where blood is given for bleeding, including the use of ratios of plasma and red cells in certain situations. And the results of the audit will be used to compare practice with national recommendations and to identify clinical areas for further development. So what is known about UK use of FFP for paediatrics? Well, there was a national comparative audit of FFP back in 2009, and you can see there was quite a peak in the infant group of FFP transfusion. There was also a study called the Easter study, which has looked at transfusion recipients where blood goes, and that identified that 9% of FFP was going to paediatric recipients, which of course is a relatively high amount, and 12% of patients who had cryo as well as FFP were children. In that FFP National Comparative Audit in 2009, they asked the question, what is the main reason for transfusing the FFP? And for infants, it was very interesting because a third of them received the FFP for bleeding, but you can see in this larger peak, actually 42% were given FFP simply for abnormal coagulation and no bleeding and no invasive procedure. So this is clearly it suggests some use of FFP inappropriately, particularly with the difficulty of identifying abnormal clotting in neonates. Overall, as I'm sure you're aware, there's very little evidence for use of FFP in the prophylactic situation. It's known that minor abnormalities of the PT and the APTT are poorly predictive of surgical bleeding, and that there's actually a very poor effect of giving FFP in normalising those figures. And again, I'm sure you're very aware of the excellent study back in 1996 from the Northern Neonatal Nursing Initiative showing that there was no benefit of giving prophylactic FFP to preterm babies at birth in order to prevent intraventricular hemorrhage. And finally, there is this, the difficulty of actually defining coagulopathy in a neonate. Of course, when one's deciding whether it's appropriate to transfuse a patient, one's also got to balance that against the risk of transfusion. And we have data on the risk of transfusion in the UK from the National Haemovigilance Scheme, SHOT, and this slide shows you the data in paediatric patients from 2015, looking at adverse outcomes of transfusion, subdivided into different categories. And I won't go into it in detail, but the blue are the neonates, and the top top 2 are actually errors of transfusion. They particularly feature for neonatal transfusions, but neonates also feature in transfusion-associated circulatory overload, for example, which is again something one wants to be considering when you're thinking about should we be transfusing or not. There are guidelines on transfusion, recent guidelines in the paediatric and neonatal population, published in 2016, with a writing group of clinical and laboratory specialists, including a neonatologist, and they aim to be pragmatic and practical based on the evidence where it exists. And there are some bookmarks highlighting the key principles, which actually I have some outside if anyone would like them. And for FFP, those guidelines recommend that it may be of benefit in neonates with clinically significant bleeding or prior to invasive procedures with a risk of significant bleeding and who have an abnormal coagulation profile. That clearly is not easy always to define. There's no evidence to support the routine use of FFP to try to correct abnormalities of the coagulation screen alone in non-bleeding neonates. And FFP should not be used for simple volume replacement or routinely for prevention of IVH. And we also put in a key practice point, this is not evidence-based but pragmatic, that a policy of routine coagulation screening is inappropriate as results are difficult to interpret in neonates and routine testing may lead to increased transfusion of FFP without benefit. So those are the standards that we will be including as part of the audit. But also in the guidelines there was an algorithm about the management of massive blood loss, which may be appropriate for neonates as well, although clearly this is all based on adult practice and evidence. So finally, to come back to the details of the audit, it commences on Tuesday, as I've mentioned. It will run for 3 months. All UK NHS trusted independent hospitals have been invited. It has an organisational section, just general questions about protocols and ranges, etc. And to an audit tool based on each transfusion episode. It will be envisaged, each trust will run it as they wish, but probably in the main it will be transfusion practitioners doing the main part of the auditing, but clinicians are vital because the audit is asking about what was the reason for the transfusion. Was abnormal coagulation part of that? And this can only be answered by the clinicians who made the decision. It will include all neonates and children less than 18 years of age receiving either FFP, cryo, or any transfusion for bleeding. And the maximum number of episodes for each would be 20 each of FFP, cryo, and 10 bleeding. But that actually, I want to emphasise that's very much the maximum. And many hospitals, most hospitals, would transfuse far fewer neonates and children during a 3-month period. And we're really keen to include all of those. So I hope you, most of you may be aware of this audit, and please come and ask me more details if you've not heard about it yet. This is the acknowledgements of the project group. Just as your neonatologist, the neonatologist in the group is Paul Clark from Norfolk and Norwich, and the main acknowledgement, of course, will go to the participating hospitals. So please come and ask me any questions in the break. Thank you very much.
Thank you very much. Thank you, Dr. Lee.